Hey everyone, good to see you. Welcome to the University Department of Psychiatry Grand Round. I'm Jeff Katzman, the Vice Chair for Education, and it is my honor and pleasure to introduce our two guest speakers for today. So I'll go ahead and get started so that they have some time to speak. First, we have Dr. Nina Higgins, who is an assistant professor and fellowship-trained reproductive psychiatrist at the University of New Mexico Health Science Center in our department. She completed her general psychiatric residency at UNM in 2015 and her reproductive psychiatry fellowship at Brown University in 2016. She specializes in evidence-based treatment of mental health disorders in the perinatal period and provides psychiatric services directly to patients, as well as consultation to providers through several specialty clinics. In addition, she created the UNM Reproductive Psychiatry Fellowship Program in 2019 and serves as Fellowship Director. It is, I think that most will agree with me about how fortunate we are to have Dr. Higgins with us and everything she's done to create a fellowship that is so very popular with our trainees. Also today, we have Dr. Jennifer Crawford, who is an assistant professor and clinical psychologist at the University of New Mexico Health Science Center, Department of Psychiatry and Behavioral Sciences. She completed her PhD at UNM in 2016 before completing a VA Advanced Fellowship in Women's Health at the VA San Diego and UCSD. She returned to UNM in 2019 as faculty in the Division of Theory and Behavioral Health. Her research and clinical interests center around improving access to evidence-based mental health care among underserved women. She provides clinical supervision and research mentorship to learners from psychiatry, psychology, and OBGYN. And we are so fortunate, Dr. Crawford, as well, to have you in our department as well, and fortunate to have you speak to us, both of you today. So I will, without taking any more time, pass the baton to both of you.
Thank you so much, Dr. Katzman, for that very kind introduction. Dr. Crawford and I are really proud of the work that we're doing and the services that we've created here at UNM for women's behavioral health, and are really glad to have this opportunity today to share a little bit about what we're doing. So let me share my slides. Is everybody seeing my slides?
Yep.
Yes, okay, perfect. Okay, so no disclosures for us to report. Our objectives today are going to be, we're going to start by defining terms related to reproductive psychiatry, perinatal mental health, and understand our population of focus. Understand the need for specialty reproductive psychiatric and psychological services. Learn about the co-located reproductive psychiatry and psychology clinics that we've created here at UNM. Describe the reproductive psychiatry and women's health training opportunities that we've created for our learners. And then identify some future directions for continuing to meet the needs of this patient population. So first, we'll start with some definitions. What do we mean when we say reproductive and women's behavioral health? Those are really umbrella terms to describe the psychiatric and psychological mental health needs during the reproductive years, including the perinatal, pregnancy, and postpartum periods, but also behavioral health concerns related to or exacerbated by other reproductive processes, urogynecological conditions, and other related concerns that are usually treated in a women's specialty medical setting, usually an OBGYN setting. Perinatal mental health is the new onset, recurrence, or exacerbation of a mental health disorder during pregnancy or the postpartum period, but also including loss. So women that have had miscarriages, a fetal loss in pregnancy, a stillbirth, or couples that are dealing with infertility. And that includes both the psychiatric and psychological services of that population. When we say reproductive psychiatry, we are usually talking about the medication management of mental health concerns during the perinatal period, but that can also include the medication management of other reproductive processes, like people that are having mental health issues related to their menstrual cycle or during the perimenopausal transition. When you hear someone talk about maternal and infant mental health, we're referring to the social and emotional well-being of the very young child in the context of the attachment between the child and the primary caregivers, beginning at birth and extending through the preschool years. The majority of our talk today really is going to focus on perinatal mental health. That really is the bulk of the patients that I see and the bulk of the referrals that we get to our specialty clinics. So in the next few slides, we'll explore the impact of perinatal mood disorders, but first let me make a quick comment. So I've noticed that anytime I tell somebody that I treat mental health disorders in pregnancy or postpartum, there tends to be a lot of misconceptions about that. Kind of thinking it's a little bit of like a boutique specialty, that it's just postpartum depression, that that's usually mild, it doesn't really affect that many people, maybe it goes away on its own. And then the next question often is, are there even enough patients for you to see? So I'm hoping that will help dispel some of those myths today. Okay, so we're going to talk a little bit about the statistics and who's impacted. So 4 million women give birth each year in the US. 1 in 7 women of those women, or 600,000 a year, will experience perinatal depression related to live birth. If we include those who suffered a miscarriage or a stillbirth, that figure rises to 900,000 a year. Multiple studies have found that depression is the most common during the perinatal period, and women are more likely to develop depression during the first year after childbirth than any other time points in their life. Anxiety rates are also higher in the perinatal period than in the general population, and less than 30% of women who screen positive for depression or anxiety seek or receive treatment. And those last 3 points are really important because these symptoms don't just necessarily go away because somebody is no longer in the postpartum period. In many women, these symptoms persist, and some don't seek treatment for years. So if there was a way for us to increase access to women during this time period, we could really prevent a lot of suffering. African American and Hispanic women are at greatest risk for perinatal mood disorders and are also negatively impacted by the disparities to access to care and the fragmented care that often happens. Fathers, we don't often talk about that a lot, but fathers are also at risk of depression during this time period. 5 to 10% have a risk of depression related to the birth of an infant, and that can increase up to 50% if mom has perinatal depression. So a little bit more about the specific types of perinatal mood disorders that we see. And again, like I said, it's not just postpartum depression. Something that was talked about when I was in my training is maybe pregnancy was a time that was protective against depression and anxiety. Studies have shown that that is not true. Prevalence rate of around 15 to 20% of depression and anxiety in pregnancy. And that's probably the biggest risk factor of somebody having symptoms postpartum, is having symptoms in pregnancy. Postpartum depression has a rate of about 21%. We also see a very high rate of anxiety disorders during this time period. So perinatal panic disorder with a rate of about 11%. Perinatal OCD, about 11%. Those women usually have very intrusive thoughts about baby safety, is usually the most common thing that we see, with some pretty compulsive behaviors to check on baby safety, which interferes with work, interferes with sleep, interferes with the secure bond that we're hoping to create during this time period. Perinatal PTSD has a prevalence rate about 9%, and that's both new onset from either a traumatic delivery or baby being in the NICU. But this is also a time of a exacerbation of a previous diagnosis of PTSD, especially women that have had a history of sexual trauma, this sort of time period where your body is not your own and the delivery process can be quite triggering for women. Bipolar disorder for women, this is also a very vulnerable time for them. Women who are taken off of their medications during this time period have a relapse rate of either a manic or depressive episode of about 70%. And even women that choose to stay on their medication still have a relapse rate of about 30%. And these women are so vulnerable because they tend to be on more complicated medication regimens. And I think there can be more of a knee-jerk reaction to just take them off of everything because providers are concerned. And it just puts them at major risk for having a depressive or manic episode, both in pregnancy and in the postpartum period. Postpartum psychosis is something that affects about 1 to 2 in 1,000 deliveries, but a much higher rate if you have bipolar disorder. And this is a psychiatric emergency because of its risk of suicide and infanticide, about a 5% risk of suicide, 4% risk of infanticide. So this is something we really cannot miss. So despite those numbers, this is a field that continues to be underfunded. This graphic is looking at the amount of grant dollars that from NIH and CDC that go to medical conditions that affect women with similar prevalence rates. So heart disease affects about 1 in 5 women, and that gets $3.3 billion. Breast cancer, which affects 1 in 8 women, gets about $1.4 billion. Lupus, which affects 1 in 200 women, gets 197 million. And then perinatal mood disorders, which we've just mentioned, has a rate of about 1 in 7 women, is only getting about 54 million. So now moving on to the consequences when these disorders are not treated. So let's start with the most serious consequence, maternal mortality. So there are committees across the country called MMRC that review the deaths in pregnancy and up to a year postpartum and look at what were the most common causes of death. They make an opinion on if those deaths could have been preventable, and then make recommendations about what we can possibly do to prevent those deaths in the future. So as you can see from this pie chart, the largest cause they found, and this is looking at the years between 2017 and 2019, were related to a mental health condition, 27%. And this is something that was even surprising for me working in this field. Before seeing this information, I probably would have guessed that the #1 cause would have been something medical. But when they looked at the numbers, 53% of the deaths occurred between 7 days and 1 year after pregnancy related to a mental health condition. And they felt that most of those deaths could have been prevented, and the advice they gave was to have more access to specialized mental health for this population. Okay, moving on to other consequences of untreated mental illness in this time period. So I think this slide is really important, especially for providers who are potentially doing treatment for women in this time period, and especially if you're somebody that prescribes medication. I think a lot of providers spend the majority of their time talking about what the risks are to a particular medication you're considering in pregnancy. And while that's a very important conversation for us to have, there's very little time that is spent on what is the risk to you in your pregnancy if your mental health is unstable in pregnancy. So let's go over those now. So first of all, you have an increased risk of your symptoms worsening in the very vulnerable postpartum period. Women who have unstable mental health are less likely to, they're more likely to have poor prenatal care. They're less likely to take their folic acid or prenatal vitamin, increasing their risk of baby having a birth defect. They're less likely to attend their regular prenatal appointments, where we can be catching things like high blood pressure, gestational diabetes, or other complications that we could potentially have treated earlier in pregnancy. They're at increased risk of having preterm labor, low birth weight. They're at increased risk of cortisol, which is when your body is stressed, which happens when you have an unstable mental health condition. You release the stress hormone cortisol, which does cross the placenta to baby and has negative impacts on fetal brain development. Increased risk of difficulty bonding with baby. These women are less likely to breastfeed. And then the children then have increased risk of behavioral issues and mental health problems later in their life. And that last point is very interesting. So many reasons why we think that this might be the case. There's probably a genetic component. There are all of the environmental factors that a child would have an increased risk of mental health disorders when their parent has a mental health disorder. But we also think that the stress on the body in pregnancy of a mental health condition is an independent risk factor for complications in pregnancy and the fetus having negative consequences. So this next graphic is taken from a talk by one of the major researchers in the field of reproductive psychiatry. His name is Lee Cohen, and he's at MGH. And so this shows how we think that maternal stress or depression might be its own independent risk factor. So maternal stress or depression dysregulates the HPA axis, which increases CRH and cortisol. CRH stimulates labor, which increases the risk for someone having an early birth or preterm birth. Elevated cortisol levels decreases placental blood flow, and we think that increases risk of the baby being a lower birth weight. CRH and cortisol in utero affect the fetal HPA axis, which we think causes dysregulation of that axis, increases reactivity to stress, and then increases this vulnerability for mood and anxiety disorders later in life. So what I hope that I have gotten across so far is that perinatal mood disorders are common. They have major consequences to patient, families, children, if they are left untreated, and that this population needs specialty care with providers that have a sense of the very unique risk factors, barriers to care, and benefits of early detection and treatment. With that, I'm going to turn it over to Dr. Crawford, who's going to talk to us a little bit more about who else in our system benefits from specialty care and a little bit about the clinics that we've created to try to meet this need.
Great, thank you. Ina, I think you can see my screen. Great. So Dr. Higgins is just hopefully giving you a very clear picture of the benefits of a need for specialty care, or at least consideration for this population, but who else benefits from the availability of specialty care? Well, I think the healthcare system and other providers benefit greatly from the availability of this. Often, especially OB-GYN providers and sometimes behavioral health providers may feel uncomfortable managing behavioral health care for pregnant patients. They may just not be up to date on the evidence-based treatment, including medication and therapy, or like Dr. Higgins mentioned just earlier, they may be overly focused on the risks of medication rather than the risks of the untreated mental illness during the perinatal period. And we hear this a lot from both patients referred to the Journeys Clinic and from providers. Well, I just stopped X medication as soon as I learned I was pregnant. Or no, I took that patient off that medication because she's pregnant. And without really having looked at the pros and cons of that decision and without making the decision with all the information that you should have, which includes that risk of untreated mental illness. Also, the perinatal period is time limited, right? I know this from recent experience. You're actually not pregnant forever, even if you feel like you're going to be. And that perinatal period of increased risk, there's sort of this peak period, but it's difficult for some healthcare systems to provide the care as recommended for patients with mental illness during that period, which would be a monthly visit to check in. And especially with medication management and consultation, really making sure that medications are at a just effective dose, that the titration that you may need to do if you're switching meds, all of that is handled with a really close level of care with a provider throughout. So the risk of loss to follow-up is pretty high with this population. Also, I think especially this is an issue we think about a lot in New Mexico, but the behavioral health workforce benefits when there are specialty care providers in women's health and perinatal mental health available. And we're going to talk more about that in the upcoming slides with the way that we include education and training in our clinical services. And then also, maybe I have a little bit of a bias here, but I think clinical and health services research really also benefits from capacity building within clinical spaces, providers who have the expertise in this and can be thinking about innovatively what kinds of research questions do we need to be asking and answering to better serve our patient population. So as many of you know, at UNM, we've really, in a lot of different places, increased our focus on integrated behavioral health care, especially in primary care settings. And if you've seen me talk before in grand rounds in the past, you know that I really can give you a whole spiel and soapbox about the role of specialty women's health settings and as an opportunity to provide behavioral health care to women. And that's because a high number of female patients primarily utilize women's specialty care. They don't even have a primary care provider. I wish that we may need to put in a QI request to ask this question, Nina, but I wish that we knew, maybe even just from our ad hoc form, yes or no, does this patient you're referring to us have a primary care provider? Because often, more often than we would like, the answer is no, which creates barriers not only to preventative health care and all the benefits of primary care that patient is missing out on, but also limits continuity of medication management and management of her mental health conditions following the postpartum period if there's no one to take over that care down the line. So a lot of those women are not benefiting from our efforts to integrate behavioral health into primary care settings. The number of women being seen primarily in women's specialty care, of course, increases during the reproductive years. If you look at women who are insured publicly, the numbers almost double, upwards of 40% or higher of those women who are really just seeing an OB-GYN or a nurse midwife or an NP in those settings, and they're not seeing someone else for their general health. Okay. It also increases among women with comorbid urogyne medical conditions like chronic pelvic pain and other painful pelvic conditions. And from some research that we've done here at UNM, looking at national EMR data, we know that the amount of unmet behavioral health need in women's specialty care is similar to the behavioral health needs seen in family practice settings. So back to that question Nina mentioned earlier that she often gets when she mentions the kind of work she does. Sometimes people think, well, there's really not that much to do in women's specialty care, right? Like, can't those patients just go somewhere else for it? The answer is there's an equal amount of problem to solve. And so unless we want to double the amount of problem solving happening in the places that are already stretched thin, this is why I'm encouraging, let's do it here where the patients are located. Let's do it in specialty care. Co-location is a form of behavioral health integration. It's not the highest form. It's not the form of behavioral health integration that we all want to aspire to. And ideally, our programs would move toward a greater level of integration while maintaining access to the specialty services that we're arguing are really needed. Some of the advantages of co-located care include, of course, being all under one roof. We benefit greatly from being primarily located at the UBank Women's Specialty Care Clinic on UBank, where we share a building with OB-GYN and UroGYN and certified nurse midwives. There's a corner of the clinic for peds specialty care as well. It's just really nice to be able to connect with those colleagues in a physical space, especially in this time of Zoom meetings. And also our staff, our clinic support, right, have the benefit of really understanding the patient population from this sort of 30,000 foot view, right? Our supervising nurse RN, our MAs understand this population from a level that's not just medical or not just behavioral health, but really the whole picture. And everyone can be on the same page as far as medication. I think 80% of the messages in our pool are between Dr. Higgins and her psychiatric team of learners, helping other providers understand what kinds of meds to provide to a patient, answering quick questions, curbside consults, that sort of thing. There's also an increased ability to co-manage the side effects of medication or the risks of medication that would need to be monitored based on additional things that may be occurring during pregnancy, like gestational diabetes, monitoring cardiac defects with lithium, for example, is really important. And one thing I'll tag on to that is just anecdotally being able to co-manage cases as a psychologist with such a great psychiatric colleague like Dr. Higgins, is that I really see the benefits to patient care when there's a conversation happening interdisciplinarily about how do we best manage the medication and the psychotherapy needs for this patient who is also dealing with something with the MFM team. And there are serious things happening, and how do we all kind of use our expertise collaboratively to provide good care. So I mentioned curbside consults. This also, by the way, has improved time to treatment. When our clinic is at full capacity, meaning we have 2 full-time psychotherapy providers, that we have as much of Dr. Higgins' time as we can have, and a fellow and interns and postdocs, our time to treatment can actually be pretty reasonable. Right now, we're scheduling out into January and February, but in a lot of cases, the time to treatment for both medication consult and psychotherapy in our clinic would be much faster than a community referral. So those patients are being able to see somebody sooner than if they were referred to the community for similar specialty care. And I'll just, you'll see that we've had really great opportunity to provide specialized training to learners and related research and quality improvement opportunities. So let's take a look at the Journeys Perinatal Mental Health Clinic. Originally, it was created by Dr. Del Fabra with help from Dr. Kane in 2014. And in 2017, it moved to the Eubank Clinic, which had just been renovated. That was an old bank, I understand. And they were like, hey, we've got space for this. And everyone was like, great, put Journeys there. Let's make it happen. We're in the back hallway there if you ever visit the clinic. And Dr. Higgins came in 2017 to take over the medical directorship of Journeys after her reproductive psychiatry fellowship. I joined in 2019, acting as a clinical director and consultant for our therapists that we had here at the time. And we've recently transitioned one of our therapist roles into a full-time staff psychologist under the UH umbrella, which provides for the first time a professional home for that position, which I think has been really helpful. Dr. Malek Yildiz is in that position, and we're thrilled and very honored to have her serving our patient population. It's just fantastic to have her here after she completed both internship and postdoc. Eubank is our primary setting, like I mentioned earlier, but some patients are seen by residents at the START clinic. And just to give you an idea of that volume that we see, when we're at full capacity, meaning our ad hoc is on, you can make referrals, we see something from 35 at the lowest end. That's like, December when providers are out half the time. 35 to 70 referrals just within the UNMH system per month. And a lot of that, and for therapy, but for therapy also within that then is most of those are also getting a medication management consult. And then there's a whole nother set almost of equal number just for medication only. Dr. Higgins, would you say it's about equal for medication only?
Yeah, that's fair.
Yeah. So something from like 70 to 140 referrals of some kind. Some for both, some for one or the other a month come through. And we expect, of course, that number would only increase with time as we're able to provide access to referrals from the community, which I can tell you that Nina and I both, when we talk about this in the community or present to other professionals or other groups, people are constantly asking us, can we send our patients to you from outside of the UNM system? So primarily the Journeys Clinic treats depression and anxiety during pregnancy and or postpartum. But just like Dr. Higgins mentioned, we also, of course, see patients with bipolar disorders, OCD, postpartum OCD, PTSD, bereavement, loss. We also serve as available, as we're able to, a smaller population of Urogyne patients. This includes a cognitive behavioral therapy for chronic pelvic pain group that I started when we came in. We've had really great success collaborating with the Urogyne division on that group, providing that additional service. Our referring providers tend to be OB-GYNs, certified nurse midwives, and to a lesser extent from the family medicine clinics here at UNM. And we work closely with those referring providers to coordinate care. And I think we see a lot of, not to toot our own horn, but positive and grateful feedback from them about that ability to access a psychiatric consult on the fly, for example, or to have a psychologist chime in about how to think about referring this patient the best possible way. Eligibility in our clinic is during pregnancy through 12 months postpartum, although we also include women who've experienced loss, miscarriage, who are trying to get pregnant, facing infertility concerns. We do exclude patients for referral where substance use disorder is the primary concern, and I'll talk a little bit later about some of the other resources for that patient population here at UNM. We do take an evidence and measurement-based approach to care in the Journeys Clinic, so all of our referrals require depression and anxiety screening measures. We conduct comprehensive intakes for all new patients, and we routinely complete measurement screeners throughout to track improvement in treatment. This also, by just a side note, this really helps, I think, Dr. Higgins and I co-manage care, because if she's seen a patient 2 weeks ago and I'm seeing them now, and we're both doing the PHQ-9, boy, we're always checking each other's scores to see that constant improvement, or hopefully see that improvement among our patients. So I've talked a lot about our patient care in Journeys Clinic. We do have individual psychotherapy and groups. Journeys Clinic really represents to me one of the fabulous collaborations between UNMH and the School of Medicine, right? We have School of Medicine faculty and learners staffing a clinic that's co-located and staffed and supported by UNMH. And so just a shout out to that collaboration. I don't think any of our team is here today. They're always busy on Fridays. But I think that's just something really important to keep in mind. We also have a slew of learners, and this has only increased in the last few years. I get very excited about it. Of course, we have the fabulous reproductive psychiatry fellows, child fellows often rotate with Nina, other psychiatry residents. We have pre-doc psychology interns, psychology postdoc fellows. I've even had Urogyne APP shadow my chronic pelvic pain group, or just find out more about behavioral health in the patient population for perinatal. We've had residents from OB-GYN and family medicine shadow or sit in. Psychiatric nurse practitioner students have rotated with Nina to learn more about medication management during this period. And we also have quite a bit of community outreach and education, both from ourselves as the sort of attending providers, but also from our learners who have presented, for example, at First Choice and provided education related to this population there. With that in mind, we do then also provide within our rotations opportunity for program development and quality improvement projects, research mentorship with me. And that's a growing program of research that from the get-go has included learners and is really exciting to work with them on growing those things. And we also have collaboration across the UNM system on service grants related to this population. So let's take a look at some of the examples of program development and quality improvement. The first intern that we were able to have in a women's health rotation, Maria developed, based on her dissertation work, a body image group for our patients at UBank. I still get messages asking if patients can be referred to this group, and unfortunately we weren't able to continue it because we don't have the staffing, but it was really helpful, especially for a postpartum group of women who were struggling with body image and changes in their body after pregnancy and birth. We also, Simi Brar, who I know many of you recall fondly, was our first reproductive psychiatry fellow. And one of the cool things that she did was develop a urogynecology consultation clinic providing psychiatric consultation in a sort of side by sort of one after the other, like same day kind of setup in the clinic with Urogyn. And I think I still hear from Dr. Andrews about how great that was serving their patients. Molecular D's, who I mentioned is now our staff psychologist, conducted some quality improvement in terms of intimate partner violence screening practices at UNM, sort of trying to figure out how well is it working? Is it happening enough? The answer is no. And what could we do to improve that? She developed educational materials presented at First Choice, has created both Spanish and English language educational handouts for patients to use in the clinic. And then this year, Dr. Rose, the current reproductive psychiatry fellow, developed a clinic. She has an interest in premenstrual dysphoric disorder and perimenopause, and has been able to provide an additional consultation clinic for that population at the main hospital. We have also, related to these issues, then comes opportunity for mentored research. And so I mentor an OB-GYN resident, Alana Yalom, Dr. Yalom, on an intimate partner violence screening improvement intervention, which has been fabulous, in part because it really created a strong collaboration between her and Dr. Yildiz. So Dr. Yildiz, as a psychology postdoc, did some of the groundbreaking QI, sort of looking at the numbers, figuring out what's going on, using her expertise as an IPB researcher previously to sort of make recommendations to the system. And along comes Dr. Yalom, who's going to be able to use her research time as an OB-GYN resident to look at how do we actually improve screening rates for intimate partner violence during pregnancy and postpartum, and what kinds of interventions would help improve that. And then our own Dr. Nguyen, psychiatry resident here, we're all familiar with Julia, hopefully, has also done really great work looking at EMR data through a Rosenbaum-funded project, looking at psychiatric follow-up after bipolar-related hospitalization during pregnancy. I just came back from maternity leave and got the snippet of data updates. It's looking like what we all probably suspect, which is that outpatient psychiatric follow-up after hospitalization in this population is low, much lower than we'd want, or much slower than we'd want. They don't have the follow-up as quickly as we'd hope. So I think a lot of good policy recommendations will come out of that. And then we also have some upcoming work with this year's psychology postdocs and interns as well that we're still working out the exact things. Going to touch on eating disorders, cannabis, and chronic pain. There's a lot of expertise that our learners bring with them when they come to UNM. And so it's really great to be able to work with Dr. Higgins and our department to grow that aspect of women's behavioral health here, allowing opportunity for those experiences. So another nod to collaborations around UNM. And this, we're mentioning these because we want this audience to just be sure that you're aware of these services. And I think most of you probably are. But in terms of prenatal care and substance use, of course, we have the Milagro program here at UNM. And Dr. Higgins and the psychiatry learners are able to provide psychiatric evaluations, consultation, co-management of care, and assistance to that family practice-based clinic, which has been really great, right? So it's not part of the Journeys Clinic, but because we have access to specialty care providers, they're able to sort of reach out and provide those services to this other program. The same goes for the Focus program, which focuses more on afterbirth, so postpartum, parents of young children, early childhood, some innovative multi-generational integrated care early intervention approach to serving parents of young children with substance use disorders and their families. Includes things like early intervention, family medical home, integrated behavioral health, medication-assisted treatment, and psychosocial support. We collaborate with them on a SAMHSA-funded grant that has been able to protect some of Dr. Higgins' time to provide consultation and supervision for the reproductive psychiatry fellow, so that the fellow can be physically in the Focus clinic providing consultation and care. And I think that, again, is one of those really good examples of being able to provide an arm from our specialty care node to help support services around the UNM system in places where it's really needed. Okay. That grant also created an additional psychology postdoc fellowship, and we've been able to keep an intern in that position, and hopefully she'll stay at UNM. And I don't know if she's here. but really doing great work in terms of thinking creatively about how to increase behavioral health access to women and parents of young children in this population. And then, of course, I've mentioned several times that we collaborate with the urogynecology division of the Department of OB-GYN with our CBT for chronic pelvic pain group and behavioral health consultation to providers. And potentially in the near future, we may be able to occasionally provide gender affirming surgery evaluations as well with that team. So additional places where perinatal mental health is happening. And I know that there's one sorely missing here, and Dr. Kane, I'm not going to forget you. But we consultation liaison juggles a lot of the inpatient referrals for this population. Of course, the ASAP clinic provides care for perinatal patients with substance use disorder. The NICU social work team screens for perinatal mental health disorders. Although we learned recently that they often provide the postpartum support international hotline, community referrals, and then to UNM programs. So there might be a little bit of a opportunity there to bridge some gaps in service. Nurse family partnership, as well as many other home visiting programs across the state screen for perinatal mental health conditions, and Parents as Teachers is a similar program that does as well. Within the community, this is not by any stretch of the imagination an exhaustive list, but a couple things that we just wanted to mention. So perinatal services and medication assisted treatment is available in the GRACE program at Lovelace, potentially also at a new program at Presbyterian, where we're all waiting with bated breath to learn more about what their program is going to look like or where it stands. And then Dr. Higgins has, I know, a sort of advocacy group in town that's close to her heart. Cassie's Cause is run by a mother whose daughter, I don't want to get it wrong.
The daughter committed suicide in pregnancy. And so she's done a lot of advocacy work in this area in the community. And so they have a support group for people that are struggling with perinatal mood disorders. And I'm pretty sure that that's what that link is for.
Yep. And then in addition to, well, just while I'm on the point of Casey's Cause providing a support group here in Albuquerque, there are also some additional resources. Postpartum Support International provides free online support groups for your patients. There's a free psychiatric consult line if you have questions yourself and you can't reach Dr. Higgins or one of our learners. It also, there is also the National Maternal Mental Health Hotline, which can be called or texted for additional help. And I'll just mention the Mind the Gap report, which a lot of our data from today came from. It provides a really nice, succinct outline of the needs of the perinatal population in the US and the gaps in service and care and research, and how lays out a strategic plan for addressing those issues. So let me just take a deep breath here and leave you with what we think are some of the next steps at UNM and in New Mexico to support perinatal mental health and reproductive psychiatry, women's behavioral health. So for perinatal mental health, we really feel like there are some opportunities to grow patient services, including coming back to full staffing capacity, increasing staffing, both for providers and clinical support, increased integration with interdisciplinary teams in our settings, potentially down the road, depending on our capacity, taking community referrals. I think as we see the continued increase in interest in this area of training from learners, we're going to be building that workforce capacity in New Mexico and potentially at UNM be able to provide that much needed service to the community. And I think, pie in the sky, one thing that could be really beneficial, not only to New Mexico, but the region, would be an intensive outpatient program that serves perinatal mental health conditions, depression, anxiety, bipolar, and other concerns in a specialized setting with a level of care that's needed. I've mentioned workforce development. There's been lots of movement lately on creating a second reproductive psychiatry fellowship slot. We're exploring options to create a women's health specific psychology postdoc position. And we'll have expanded supervision availability for psychology learners next year when Dr. Malek or Dr. Yildiz is able to provide supervision. And then I think we'll continue to see increased interest in program development and quality improvement and research among our learners, grant submissions. And also Dr. Rose is currently working on developing an echo for reproductive psychiatry for the state as well. So lots of opportunity, good work and opportunity for growth in all three areas of our mission here at UNM. And with that, I'll thank you all for your attention. We have quite a bit of time for questions. So we want to open up the floor to any of those. I'm just checking the chat. Yeah, Jennifer Nanez. Hi, good to see you.
Hi there, good to see you in a wonderful presentation. I just wanted to ask if, and I think Teresa asked earlier in a direct message, if you have any data for American Indian women, for one, and two, to consider working also with tribal home visiting projects, as well as early childhood programs in this avenue. I think it's really needed, and also that additional component of cultural responsive care for our American Indian population, mothers and children, will be very helpful, I think, in promoting these efforts too. Thank you.
Yeah, thanks, Jennifer. So I was quickly trying to find stuff when Teresa messaged me, but I'll have to get back to both of you in an email later because I was doing a bad job doing three things at once, paying attention and doing that. So I will get you those numbers. I don't want to quote them off the top of my head, but I think they are quite similar to the increased risk that we mentioned for African-American women and Hispanic women. I think anecdotally, at UNM, I have a suspicion that there probably is a referral gap for American Indian women, that where they are when they come to UNM, maybe from over a great distance for services for perinatal pregnancy and labor and postpartum or NICU, that there maybe are some there's fragmented care happening, and it's reducing the referrals to our clinic. Now, I will say that during COVID, when we were able to use telemedicine, and we've been able to continue doing that, we probably have seen an increase in patients from farther off stretches of the state, including American Indian patients, coming to our clinic because it was the barrier of transportation and a long drive was eliminated. That has helped lots of patients in this population, frankly, but I think especially that group probably benefited. I can see your CBH hat on, Jennifer, thinking about partnerships and home visiting and community-based programs. And I think all of those things are on the table. I think in terms of perinatal mental health, the Journeys Clinic in UNM, in terms of patient services, one opportunity that I hope we can think more about over the next few years is providing telemedicine to the new or relatively new ultrasound clinic in, I think it's in Gallup.
Mm-hmm.
They're providing, where staff are driving there, providing ultrasound to reduce barriers to prenatal care. And there is space in that clinic to provide direct to clinic telemedicine. And so I think behavioral health, mental health care to that population would be a really direct route for increasing access. So thanks for your question.
Thank you.
Avi?
Just to start with, just a absolutely wonderful presentation by both of you, so necessary and just like a model of a comprehensive kind of understanding of all this. I had two questions related to what you were first talking about the high mortality rate and how it connects to mental health. And I was wondering how much that relates to access to mental health services. And a related part of that is, I know that for the lack of prenatal care, a lot of that is associated with anti-abortion laws, which oftentimes are connected to the lack of any kind of prenatal care and counseling.
Right. Yeah. And we didn't even sort of figure in the, like, how is this all these new rules in many of these states, how is that going to impact the work that we do? And I'm sure it's just going to increase all of our numbers. But as far as your original question about how much of that, those mortality rates were related to women not having access to mental health care, I'd honestly have to look at the numbers. I'm not sure. I'm happy to look at that report and give it to you. I would imagine that it's quite high, especially since the main recommendation that came out of that committee is increased access to care.
Is that your experience here in New Mexico?
Say that again.
Is that your experience in New Mexico, that a lot of people who have bad outcomes is because they had limited, if any, access to mental health services?
It seemed like it. So I served on that specific committee for about 2 years, and some had there was some point that they saw someone along the way for mental health, but not consistently. So yes. Angelica?
Hey, hi, Dr. Crawford, Dr. Higgins. Thanks so much for your presentation. I had a couple of questions, and one of them was similar to Avi's, which is just, kind of wondering about how anti-abortion laws have impacted birthing folks and how that's changed your work and the work that you do, whether it's, changed after birth or just not having access or things like that. And my other question is surrounding birthing folks that aren't women and how the clinic captures those people, if there are any extra efforts, just because we know there's lots of non-binary folks and trans folks who have children as well.
Absolutely. Yeah, absolutely. So I think me and Dr. Crawford would be very happy to serve the trans community that are birthing children. Honestly, I haven't seen that many. Dr. Crawford, have you had very many of those patients? I'm not sure if they're being served at Truman or where those patients are getting service right now. I think we'd be very happy to be able to see those patients. I just don't have any personally right now.
I think it's a great question. And I don't have the answer. I know that within the OB-GYN department, it's been a topic of conversation for a while of sort of what are the needs of that population within their services and what does that look like, and a lot of thoughtfulness going into inclusive language and services. And so I would say that especially gender non-binary and trans patients that I have directly worked with over the last 3 years have primarily come through Urogyn and are being referred for chronic pelvic pain or related conditions. And that may just be that it's just a fluke of the system or a gap in care, fragmented care. And so I think it's a really great question. Yeah.
I think we're happy. We would be happy to see those patients. And then your other question, Angelica, about how has sort of the change in the laws when Roe versus Wade was overturned, Wade. I don't necessarily know that we've seen the impact of that yet. We sort of saw it more. We were supporting our colleagues who suddenly got this influx of patients coming from other states that had bans. So I feel like we were that's where we've seen it the most, is supporting our colleagues that were overrun with all of these patients that they could not serve. But I'm sure in the coming years, our numbers are just going to increase, because if women have such high rates of mental health disorders, even when a pregnancy is desired, how is that going to change for women that have no choice in their decision? I can only imagine it's going to increase.
I will add,
absolutely. Thank you so much.
I will add, just recently, I think I sort of saw the impact of misinformation around abortion as it blew up in the national conversation. Sort of misinformation contributing to distress in a patient. I'll just leave it there. That sort of her access to reliable information is limited. And so misinformation was kind of adding to distress in terms of making decisions about her health. Yeah. Great questions. I have a question for you all, if you'll indulge me on a Friday afternoon. I'd really love to know what types of perinatal mental health questions have come up for you in your settings that it might be helpful for Nina and I to hear, so that we're aware of where our specialty input might be helpful, where it's not already available, or the kinds of challenges that come up when you're providing care for this patient population. And you can always email us too if you have those questions later.
I will just say
I'll
as a
say for
comment.
me,
Oh, I was going to say this isn't directly related to your question, but having Dr. Higgins available as an instructor in the resident clinics has been very helpful, I think, in almost like giving us a little bit better understanding of some of the questions that we might see. And so it's almost, for me, having her there has contributed to an education of like minimizing those problems later on in practice, if that makes sense.
Wonderful, Molly. So happy to be able to be there for you guys in that way.
Mm-hmm.
Hey, Nina and Jennifer, this is Brant Hager. I was just curious about some form of a centralized location for links to these various resources. There's a lot of different resources that are offered through some different locations for different aspects of reproductive psychiatric care. And I'm wondering about collating some sort of a centralized resource so that if somebody does an internet search for reproductive mental health or perinatal mental health or women's mental health, that something can come up on a UNM related website that can be like a clearinghouse for all these different resources. And I think it could be of benefit to the psychiatrists and the therapists in the community, as well as we try to remember the different resources that we can offer and bring to bear for people with these conditions. I don't know where exactly that clearinghouse would live. Maybe it's on the Department of Psychiatry website. Maybe it's through OBGYN. But there's so many great things out there that I just forget about all the details sometimes. So it'd be helpful to have an assist with that. And to get to your question, Jennifer, regarding what kinds of questions end up coming up in clinical settings. So I mostly work at Truman. So most of the questions that are coming up in my clinical setting are about family planning questions for our trans folks. And then navigating psychiatric treatments within the context of potential pregnancy, regardless of the gender identity, and addressing fertility concerns, addressing teratogen concerns. When I was working in other clinical settings, it was mostly questions pertaining to appropriate medication treatment during pregnancy and planning for the peripartum care. So yeah, thank you for your presentation. Really appreciate it.
Thanks for your comments. And I think, I don't know, someone can email us later and tell us who to talk to about getting a good website up. I think that's a great idea to connect it to psychiatry's department page and probably OB-GYN. We could just link it all. People can find it from multiple directions.
Right. And Brant, thank you so much for bringing up that point about the like preconception consultation, because that isn't something that we really mentioned in our talk, but a major thing that we do is preconception consultation for patients considering a pregnancy, even if we're talking, you know, they're thinking about it in a couple of years and it's not like an imminent thing. That is something that we very commonly do and would welcome patients for those consultations.
Yeah, thank you so much.
Well, thank you all for your attention and great questions and comments. We really appreciate it. And enjoy your weekends.
Thank you.